Pathology Exam 3, second part of everything that you need to know for the exam. Now we're talking about thrombi. Starting off, you understand that it's the endothelial integrity that is the most important factor for thrombi. So in the case of any thrombi, you need to remember Virchow's triad. So there's three different factors that can lead to a thrombi. But we're just going to jump right into the different types of thrombi. You understand that there are different ways of classifying thrombi. You can have an ante-mortem thrombi, or you can have a post-mortem thrombi. Ante means before, and post means after. Mortem means death. So this is an ante-mortem, means a before-death thrombi, and this is a post-mortem, meaning an after-death thrombi. So if you are performing an autopsy and you open somebody up and you want to find out, well, did this thrombi happen before they died or after they died, you could look at this and actually make that determination. So starting out, if you open somebody up and you look inside of them and you see a thrombi, and you see that the thrombi is dry, meaning that it's made out of more like tissues as opposed to red blood cells. If it's dry and granular, meaning that it has a granulous tissue in it, and you find that it's really stuck to the walls in there, and then it has something called lines of Zahn. Lines of Zahn being basically a layer of platelets and fibrin, and then a layer of red blood cells, and a layer of platelets and fibrin. So kind of like this white red thing on the inside of blood vessel, or if it's red or white. These would be things that would indicate this is an ante-mortem thrombi. Whereas if you were to look at somebody, open them up, and you see a thrombi, and you see that it's gelatinous as opposed to dry and granular, it's gelatinous, it looks like a jello almost, and it's not stuck to the walls, and it doesn't have any prominent lines of, or doesn't have any lines of Zahn in it. It doesn't have that, it hasn't been healing. This happened, it's clotted up afterwards, and it almost looks like red or black jelly. And you look at it, and the top of it is this yellow color, and the bottom is just all red blood cells. Then you would say this must be a post-mortem thrombi. There's also another way to divide these. You can also divide them between venous and arterial. So if you see a thrombi and you want to know, let's say it's got stuck somewhere, you want to find out is this a venous thrombi or an arterial thrombi, you could actually tell by looking at it. So a venous thrombi is going to be mostly composed of red blood cells with a little bit of fibrin in there, just a tiny bit, but pretty much it's all red blood cells, so it's colored red. Okay, so you look at a venous thrombi, it's this big red thing of red blood cells. And this makes sense when you think about it. Now the venous system is moving much more slowly, and the problem that you get with the venous system is stasis. In other words, things stop moving, they're just holding still. They hold still, they kind of start to descend. It's almost like a jello mold. They start to clot, almost like cement or jello. Whereas these arterial ones, this is like a lot of pressure, high pressure situations, lots of turbulence, injury sites, those sorts of things. But going back to these venous ones, this is just something where the blood's sitting there, so it forms this big gelatinous kind of, or this big red blood cell thing. And usually, since it's all the blood, it's going to be occlusive, which means it's going to block off the whole blood vessel. So here's the blood vessel. This thrombus is going to fill up the whole thing. So it's occlusive, okay? And typically it's going to happen in places where you're likely to get stasis. For example, the legs. Women who are pregnant will get those large blood vessels, or people that sit down all the time can have the blood just kind of stay in there without moving their legs, and it can cause these sorts of things. Typically they happen in the pelvis blood vessels or the leg vessels, and they grow in the direction of blood flow. That's actually one thing both these kind of share in common, is they're both growing towards the heart. But you got to note that in the case of venous, towards the heart means in the flow of, they grow in the direction of blood flow because it's going back to the heart. And these guys, they're also going towards the heart. But since the blood from an arterial is flowing away from the heart, it grows retrograde, so opposite. It grows towards the heart, which is the opposite of the direction of blood flow in the arteries. So when you're looking at these arterial ones, they're going to appear as white. And the way that I think about this is, since these ones are mostly red blood cells, this one is kind of tissue that's sort of healing over. That's why it looks white. White's tissues more white than red blood cells. They're going to be in areas where there's lots of turbulence. So you think about, the highest turbulence areas probably going to be coronary artery first. The next one, next is closest to heart, is probably going to be up here in the cerebral, and then further away you might get down the femoral artery. But you need to worry, about these high turbulence areas. Lots of turbulence causes some of these clotting mechanisms to be activated. It's also going to be at sites of injury. So if you've got some area in there where there's, something's hurt, and these ones are not occlusive. So if you've got a blood vessel like this, an arterial one, it's going to be white. So I'm trying to find some good color to represent that. Here's orange, close enough. It's going to be more like this. You're going to see those big lines of Zahn in it. Now technically these ones do have lines of Zahn, but it's very, very faint. These ones are the ones that you would really say have those lines of Zahn in it. Almost looks like candy cane, red, white. Next, actually I just stated everything about that. So now going on, there are different types of, different fates of these emboli. So now these have formed, let's say one formed, in the venous circulation, and it's going to break loose and it's going to start flowing through the bloodstream, and they're going to end up somewhere. It's going to get stuck somewhere. Something's going to happen with this thing. So there are a few things that can happen. One is it can cause stenosis. So basically a narrowing of the blood vessel. It's kind of stenosed. So that's kind of illustrated there. See, this is still open, but that's where it's formed. Sometimes it can also form. It can undergo retraction. I think retraction is basically where it's flowing through, and then it gets stuck again somewhere. And when it gets stuck again somewhere, it can cause either a partial or a total occlusion in a blood vessel. That can be very bad. It can also have a recanalization, which I think what that means is that either it can kind of open up again and blood can flow through it, or I think that means that other blood vessels are formed. I'm not sure on that one, so I'll have to look that up. Next, it can form webs or bands. My understanding of that is basically that it could kind of stick in different places and kind of be like a band or a web across it, so the blood could maybe still flow through, but not all the way. To double check that one as well. But half of them are reabsorbed within 8 weeks, and that is basically just has maybe a little bit of blood vessel narrowing. Next is the pulmonary thromboembolus, and we want us to make a special note here. This is not a disease. This is like a symptom of another disease. The pulmonary emboli are the most serious form of thrombi, pulmonary thromboemboli. So in the case of these, it's usually going to be from a vein, and often it's the femoral vein. What happens is, you'll get a thrombi in your femoral vein, and then it'll break loose and it'll go up through the inferior vena cava, and then it'll go down to the pulmonary artery or the pulmonary vein or one of the other branching blood vessels in the lungs. And then the person, if they have symptoms, a lot of times they don't have symptoms because they're so small, but if they have symptoms, they're going to have sudden chest pain and hypoxia, and then they can die very quickly, and they'll die from right heart failure. And this will typically occur when there is less than 60% of the pulmonary circulation. The other kind here is going to be a saddle embolus, and a saddle embolus is when there is this can occur basically when a thrombi goes up and there's this branch between the left and the right pulmonary arteries, and it kind of just gets wedged like this, kind of like a saddle almost between those two arteries. And when it's stuck in there, if they don't die immediately, I mean, you're going to need immediate surgery, and that's a very serious one. The other one that's mentioned here is the fat embolus, and that typically happens when you have trauma to the breast, like a car accident, or if somebody breaks a bone, like maybe when they're doing CPR, they break the sternum bones, and then the fat gets out and it goes up somewhere and gets stuck, and that can actually lead to death as well. And the last little bit of what they have here in the everything you need to know, I'm not going to cover the rest of it at this moment, but I'll just speak it or read it here. It says there are certain patient populations or situations in which we would suspect one type or another, or are there, excuse me. So yeah, there are, so you identify trauma. Oh, you're thinking trauma, you're thinking fat embolus. If you're thinking, a pregnant mother, maybe she has varicose veins, you might think venous. If it's a pulmonary one, well then you think maybe it'd be venous. You kind of connect those two. you can kind of see how these different things could connect. Also, it says make sure take a peek at the types not specifically listed in the objectives as well. So make sure you look at the different types that maybe aren't under the objectives. So look through the different types of thrombi, and also look at the different types of infarcts. And it says be good to look up pictures for these. So go through and look through the different pictures of the different infarcts. And what makes an organ prone to a red or a white infarct? So we already know the red infarcts are the venous, that's simply going to be stasis, and the arterial is going to be the turbulence or an injury site. And why are they called red or white? We already understand that. Shock, so we need to understand what is the underlying mechanism of shock and how does this explain the clinical signs and symptoms. Also, think of a situation in which you would suspect each type of shock. And we'll do another lecture on shock in a little bit. But for now, I'm going to go ahead and quit.